our final talk from Anthony Hackett, who's a VTE pharmacist at Guy's and St Thomas's, and Ellen Quinney, who's the matron for hemostasis and thrombosis and blood transfusion at Guy's and St Thomas's. So their talk is called A New Strategy for Non-Pharmacological VTE Prevention. And they're going to describe the actions that they've taken at their organisation to manage the use of non-pharmacological methods. I am waiting with bated breath to see what they hear, because we probably, like you guys, have got this unhealthy relationship with anti-embolism stockings, and certainly from certain quarters of our organisation, yeah, don't mess with our stockings. So I would love to hear Anthony and Ellen, what your experiences are. So over to you.
Thanks, Becs. So hopefully everybody can see my screen. So thanks to Thrombosis UK and to Joe for inviting Alan and I to talk about our new VTE prevention strategy that we're rolling out at Guy's and St Thomas's. It is going to be focused largely on the non-pharmacological aspect. So just to give you a start, we're going to cover about VTE risk assessments, a bit on pharmacological VTE prophylaxis, but I promise not to go into that too much. Non-pharmacological VTE prophylaxis. And what we're going to do if pharmacological prophylaxis is contra-indicated, but the patient is still at risk of VTE. So we need to think about strategies for that. And then some of the learning from the training and the rollout. So why do we risk assess? Well, we know that VTE is the #1 cause of preventable deaths in hospital. Hospital-acquired thrombosis is the #1 cause of VTE whilst in hospital and for the 90 days post-discharge. We also know that when the VTE risk assessments were mandated back in 2010, the incidence of hospital-acquired thrombosis reduced significantly. We also know we have NICE guidance, and that advocates certain recommendations for VTE prevention that will include pharmacological and or non-pharmacological measures depending on the clinical scenario. And in regards to VTE risk assessments, there are lots of risk assessment tools out there and available, and they are tailored to specific clinical conditions such as pregnancy. So it's really important that we know to use a validated risk assessment tool tailored to that various disease states. For many of us, we are familiar with the Department of Health risk assessment tool. We need to apply clinical judgment to the patient when understanding the risk assessment, particularly around bleeding risk and medication taken to the patient prior to admission. Many already may be on an anticoagulant for conditions associated with VTE or with an increased risk of stroke. I previously touched on the pharmacological measures for VTE prevention that NICE advocate, and depending on the clinical setting, the disease state, or the indication, or patient factors such as platelets or renal function, the team should ensure the most appropriate agent is prescribed. NICE recommend the first dose be given within 14 hours of admission. However, it is likely that this is a practicality issues, particularly around prescribing, that may impact the likelihood of that 14-hour standard not actually being met.
Anthony,
Sorry,
can I be rude and interrupt? It's just we cannot see your slides.
Oh, sorry. Okay, let me just push through. What screen are you seeing at the moment?
We're seeing you.
You're seeing me. So apologies for that. Let's share screen, see what's happening. What are you seeing now?
Still you.
Okay, this is a bit awkward.
Have you clicked on here?
Share screen. Yeah.
Click on screen 2.
Screen 2.
And then share.
Share.
Coming through.
Seeing now?
Yes, perfect.
Apologies, everybody. I will quickly go back to the start, if that's okay. I think we should be okay for time. So, start again. Sorry about that, guys. So we have the new strategy for VTE prevention here at Guy's and St Thomas's. And I will quickly go through the next one. So with regards to what we're going to discuss today, we have VTE risk assessments, pharmacological VTE prophylaxis, non-pharmacological VTE prophylaxis, and what we're going to do if we have a high-risk patient where pharmacological is contraindicated, but we still need that patient on something for VTE prevention. So again, why do we risk assess? Just to touch on briefly, we know that hospital-acquired thrombosis is a major factor. It is the #1 cause of preventable deaths. So we know as well that when we implemented the VTE risk assessment and made it mandated back in 2010, we've had a significant reduction in hospital-acquired thrombosis. We also have NICE guidance, which advocates that certain recommendations for VTE prevention will include pharmacological or non-pharmacological VTE prevention measures. And in regards to the VTE risk assessment, there are several tools out there. So just make sure that you're picking the right tool tailored towards the clinical condition that you have in front of you. So pregnancy, surgery, etc. We should all be familiar with the Department of Health tool. That's what most of us will use. And you just need to make sure that you're applying some, I suppose, clinical judgment to the patient in front of you, risk assessing bleeding versus clotting risk. Touched on it briefly. So with regards to NICE guidance, there is the pharmacological VTE prophylaxis. It advocates based on clinical setting, patient factors such as platelets or renal function, and also with regards to the indication that you're treating the patient for. There is a 14-hour standard that NICE recommended the patient should get their first dose within. Personally, we struggle to meet that. I'm sure other hospitals do, and that certainly will probably surrounding prescribing. So it's just being mindful that NICE do recommend that 14 hours of within admission, the patient should get their first dose. There's lots of evidence for the different types of agents being used. I've just lifted some of them there. So you've got fractionated heparin, low molecular weight heparins, DOACs, fondaparinux, or aspirin. So NICE will make all these at some stage. However, when it comes to non-pharmacological VTE prophylaxis, NICE does make recommendations to the use of anti-embolic stockings. It advises which patients should or should not receive anti-embolic stockings. But the big question is, how effective actually are they? Well, we know that in 2020, the GAP study was released, and the findings from that study indicates that anti-embolic stockings do not offer any additional benefit over low molecular weight heparin in patients undergoing surgery. And just to add some additional information about AES, it is estimated that these stockings cost the NHS in England about £63 million per year. And Salisbury Hospital, they got rid of their stockings for all patients about 10 years ago. And since doing so, they haven't identified any adverse outcomes. So there's been no increase in the incidence of preventable VTE. So this is just a nice visual highlighting the GAPS study outcome. So we can see that 1.7% of those in the low molecular weight only arm versus 1.4% of those in the low molecular weight heparin plus AES went on to have a VTE. There was no statistically significant difference between these groups. So it makes you think, what, if anything, are anti-embolic stockings actually doing? So back to NICE guidance with regards to non-pharmacological VTE prevention. We have one study that's been carried out in surgical patients showing that AES are not effective. So in that case, you need an alternative, and that alternative is intermittent pneumatic compression, also known as IPC. So looking at the literature for the evidence to support the use of IPC in VTE prevention, we find the Clot3 study, and its primary outcome was to look for proximal DVT at 30 days. Its secondary outcomes were for death, any DVT or PE, or complications of IPC, and the mortality risk reduction. Within the first 6 months, the mortality rate was 15% lower with the IPC group versus the non-IPC group. However, there was some skin breaks with the IPC group, so you do need to ensure that there are daily checks of the skin. And then a Cochrane review as well. So that showed the addition of pharmacological prophylaxis to IPC did have a lower rate of symptomatic PE and DVT compared with IPC alone. However, it is unsurprising that there was a higher bleeding rate in those with pharmacological VTE prophylaxis when it was used. So now that we are equipped with some of the evidence surrounding non-pharmacological VTE prevention, we need to consider the place of AES and IPC within VTE prevention strategy across our trust. And locally, the Thrombosis and Thromboprophylaxis Committee at GSTT have decided to extrapolate the results from GAPS to all areas of the trust. So therefore, anti-embolic stockings will no longer be used for VTE prevention. But how do we manage those who are still deemed at risk of VTE and where pharmacological prophylaxis is not appropriate? Well, for those patients, IPC will be used. However, there will be inclusion criteria for where IPC is applicable. Alan will touch on some of the practicalities of using IPC and the impact that can have on the patient. Therefore, not all patients who have a contraindication to pharmacological VTE prophylaxis will receive IPC. And assessing those who are at highest risk and who benefit from IPC, GSTT will be advising any patient who is immobile, i.e. unable to walk, a minimum of 10 meters or with an assistance of 1 will receive IPC. So before implementing our new strategy, we need to provide some reassurance to the trust, specifically around how many patients will this new strategy apply to? Will there be enough devices for those that need it? What support will be given to staff on the new device and changes in practice? And what assurance can be provided that the strategy actually will work? So with regards to how many patients the new strategy applies to was determined by a point prevalence audit. All adult wards across the trust, excluding stroke, as they have an effective plan for using IPC in their cohort of patients, and critical care and maternity, because they use a separate IT system that our auditor didn't have access to. But we've since had reassurance that they're totally on board moving away from AES and onto IPC. So of the patients that were included in the audit, 112 were not receiving VTE prevention or treatment. And of those 112, we reviewed them within the thrombosis team using the inclusion criteria, and we estimated that 21 patients from those collected would be applicable for IPC. As the wards were not at full capacity when the audit took place, we had a bit of a scale-up factor, and we determined that on any given day, there were about 28 patients who would be applicable for IPC, which equates to about 4% of the inpatient population. So taking a deeper look at the spread of those patients and which directorates they heal from, our biggest potential users were from the transplant, renal and urology team, which makes sense as these patients are post-op and are at high risk of bleeding. Hence, they're not going to be really on pharmacological VTE prophylaxis. And also because of the immobility post-op, they are prime candidates for IPC. Therefore, on recognizing this, we had early engagement with this directorate on the findings and get buy-in from the relevant stakeholders to elicit change. As we estimated 28 patients at any one time would require IPC, we increased our holding of IPC devices by 50 across the trust. And these devices will be held centrally and delivered to the wards on an ad hoc basis. And the sleeves required for the devices will remain on each ward. Supportive measures that we identified and have completed still to complete include a change in the VTE prevention strategy grand round, which will be delivered by our thrombosis committee chair to the trust doctors. That took place a couple of weeks ago. Updates to all the VTE prevention guidelines, that is a work in progress. I'm sure every hospital can appreciate resource allocation has been limited over the last couple of months. So it's a case of when we get time to do this, we work on it. VTE risk assessments and the e-prescribing systems, they all need to update it with protocols, making sure that the appropriate risk assessment and recommendations are in place. We need to update our VTE mandatory training tool for the doctors when they join the trust. And we also need to collaborate with our trust comms team to circulate wider across the trust about this big change. And finally, what assurances can we provide with that strategy will work? Well, rates of hospital-acquired VTE before and after and up to the change will be audited. Appreciate this may take some time to roll out, but we will be making sure that we're keeping regular tabs that there isn't a spike in any incidents of VTE that we identified because people aren't on stockings. But the plan would be we would do our before and after, and hopefully in a couple of years, we have enough data we could nicely publish. We fully appreciate that we have a culture of we feel we need to do something to treat our patients, or in this case, reduce the risk of VTE prevention. But if we are satisfied that anti-embolic stockings are not adding any value or protection to the patient against VTE, a change in mentality is required. And that will not only happen by going out to the wards, that will only happen by actually going out to the wards and upskilling and informing our staff. Which Ellen was great at doing, and I'm just going to hand over to Ellen now.
Thanks. So some of the considerations that we gave to training, so we started the training project by engaging with various stakeholders. So it was essential to get buy-in from our senior nursing team and heads of nursing for various areas, as they'd be the ones endorsing the project and ultimately releasing the staff and allowing them to come away from the wards to be trained in the new device. They raised some issues at the start around how it would affect patients' risk of falling. They also queried exactly what was meant by the term immobile, because it can mean various things. Does it include the patient that shuffles around the bed space but actually isn't very mobile or might need assistance to mobilise? And they raised some obvious concerns around releasing staff for training given the current climate. So some of the things that we did concurrently whilst rolling out the training programme to address these concerns was I approached the Trust Falls lead and attended the Trust Falls group that's held monthly. And we discussed how, in general, we manage patients with medical devices. We're quite used to, as nurses, managing patients attached to various contraptions, so IV lines, vac pumps, drains, and they'd be managed in a very similar way, but it was just about reassuring people that we would treat them the same as we do other medical devices, including those patients who might be especially high risk and confused, and basing it on an individual risk-benefit analysis. As a VTE prevention team, we defined the term immobile as unable to walk 10 metres with or without assistance. And that really helped the clinical teams to have clarity on exactly which patients would be indicated for this. The senior nursing team also agreed and advocated for a train the trainer model. So because of the challenges around training absolutely all the nurses, it was agreed that we would sort of identify super users and train key individuals, and they would roll out the training. Cardinal Health have got a self-assessment competency that we use to enable cascade training, that when the super users attended the training, we gave them a load of self-assessment competency forms that they could take away to their areas and use. So we tried a couple of different training approaches. We first tried a kind of roaming approach. So we would, me together with the rep from Cardinal Health, would go to the individual areas when people were on shift. The super users had been identified as being on shift. We'd go to the areas and deliver that training. And that was challenging because people get tied up in the day and it's difficult to peel people away from the pressures of the ward. We then switched partway through to more of a hub model, where we stayed in the same training room in the same place and ran the same training session on the hour every hour, so that people could drop in, and that I felt was a lot more effective. We captured more people. We did have to sort of go around and rally people up and sort of remind them, but I think it helped to know that on the hour every hour they could drop in and that we would be there. So at GSTT we've got approximately 40 inpatient wards, so it's a massive amount of territory to cover, and it became clear early on that a staggered approach was going to be required. It seemed logical to start with our own clinical group, and H&T sits within cancer and surgery. So we started and aimed our training efforts at that group first. That poses problems in terms of how you then roll out a policy, because if you've got one group of staff or one group that's trained in a device, it's a question of the timing of the policy launch, if some areas of the trust have been trained and some haven't. So as Anthony mentioned, the pumps are stored centrally through the equipment library, but the individual units would stock the sleeves in a few different sizes. So it's important to engage with medical equipment and procurement. And procurement are also responsible for the removal of the availability of anti-embolic stockings. And the removal of the anti-embolic stockings after such a long period of time being an ingrained practice for both staff and patients is almost as big a piece of work as implementing the IPC. So it's essential to update patients and have patient literature and information about the change in practice in order to sustain the change and avoid people continuing to revert back to anti-embolic stockings. It was really positive to see how staff how engaged they were with and grateful to be receiving the face-to-face training. We've certainly had a long period where face-to-face training hasn't been happening, and because of staffing challenges, training in general has taken a backseat, and there was lots of appropriate questions and lots of engagement, and staff who genuinely want to be offering as safe a care as possible to their patients. One piece of feedback that I received regularly throughout was use of the acronym IPC. So as most of you will know, that IPC for us stands for Infection Prevention and Control. So they were concerned about the confusion around that. The company actually refer to it as intermittent sequential compression. And so I think that in the future, that's probably a change in brand that we would look to do. Thank you.
Thanks, everybody. And then I will just stop sharing. So any questions?
Thanks, you two. Wow, I've got questions. I could talk about this all day with you, but I won't for the sake of everybody else. Just like, it's a really bold piece of work that you've done. And before I ask my questions, of which there are many, there is a question in the chat from Deepa, who asks, is it cost effective using IPC for all patients for whom pharmacological prophylaxis is contraindicated?
No will be the answer, because I think what we've had to identify is that not everybody is actually going to be applicable for it. If we think about what the I suppose the application actually involves, it's, you know, you're at risk. We don't want you to be hooked up to it if you don't need to be. If you don't need to be on pharmacological, that shouldn't be a straight need for IPC. When we've identified that only 4% of our inpatient stay of the areas that we audited would actually use it, I'm sure it is cost effective in that sense, because we know it's working for those high risk patients. What's not cost effective is to continue down the route of anti-embolic stockings when we know it costs NHS England 63 million a year when they don't work.
The direct costs, stockings cheaper, but if they're ineffective, then that's a waste of money.
Exactly.
Yeah. So IPC, sorry, I can't. I haven't got that in my head to not use that term.
I know, we still use IPC, that's okay.
IPCDs, we call them that. More expensive upfront cost, but effective. So it's apples and pears, isn't it? You can't really compare an ineffective method with one that is going to work.
But I think what's important to know is that the number of IPCs that will be applied to patients will be relatively low. I know we've had to create that metric of 10 meters or less, because we've tried looking through the literature and couldn't find anything that gave us what immobility would be defined as. So we've had to think what practically here we work with. So that was our metric.
So then that leaves a small number of patients for whom pharmacological prophylaxis is contraindicated, but they are not eligible for intermittent pneumatic compression. Is that correct?
Will there be a larger one? So if, you know, we look at it and go, if in today's economy right now, if you couldn't have dalteparin, you would have stockings on, and subconsciously we're all thinking, well, that's fine, but we know that's not the case. So look at the subsect of patients who can't have pharmacological and go, who are our really high risk patients? And they are the ones who will get it. Everyone else, it's just a case of, well, we have to risk assessment, and the risk of giving you pharmacological to prevent you is going to cause adverse outcomes, but you're not so at risk that we feel that you need to be hooked up to IPC.
Yeah, okay. Helpful, thank you. Now, I was fascinated, and you sort of casually threw this away, Anthony, in your presentation, but this got me. Guy's and St Thomas's Thrombosis Committee extrapolated the results from GAPS to all patients. I was like, wow, brilliant. Tell me more about that.
So we sat down in our committee meeting and we were like, this is what the findings are. What does this mean? And when we look, because we know Salisbury don't use them at all and haven't, and I think tomorrow there's published data to say sports. I think having GAPS as a trial that was done and published, we're like, do you know what? We have to make a decision, and we feel confident that actually they're not providing any additional benefit here. So although it's not been done in the medical cohort, I think you also have to look at patient barriers and nursing barriers. Like, how many times do patients they're prescribed, but are they wearing them? You know, people feel uncomfortable. So I think it's a big move and a big statement to make, but I think to elicit change, somebody has to make some big decisions, and that's what we're hoping to achieve.
Yeah. So do you plan to publish?
We will. So the idea will be that once we've implemented all this change strategy, and then we can look at our hats. Now, granted, we can't do it within 6 months because that's like, it was really robust enough data.
Yeah.
But within time, if we're able to go prior to change over to IPC for our most at-risk patients, has there been any meaningful increase in the incidence of HAT? And if we can say no, I think that is pretty good evidence to them for other trusts to say, let's make the similar change.
Okay. Another question along those lines. Multi-site organisation, 4-5 hospitals. I guess maybe Park in the Evelina, they're not part of this, but you know, complex patients across different specialties, surgeons and medics with strong opinions, if they're anything like ours. Where did you start?
So Professor Hunt is our chair of TNT.
Oh,
so we
that
have
explains a lot.
That's a good stakeholder to have involved. So we've had a big grand round, and that was pitched at a lot of the surgeons and consultants there, and we've spoke directly. So orthopedics, for instance, they still want the anti-embolic stockings, and the reason for that is that they find it helps reduce swelling post-op. So it's not being used in a VTE prevention indication. It's been used to reduce the swelling. So that's fine, that we can obviously still have some of those in the trust. But if we can say, listen, there is no evidence to support, this is just going to complicate matters, and we will reorientate training. We've had buy-in, we haven't had much pushback. I think most out there will be a case of advocates of drugs and feelings that way, but when it comes to this, they don't know themselves, so they're going to be guided by the specialists when it comes to this.
Great. Finally, I think from me, I mean, like I said, I could go on and on, but I won't. Maternity. So they were excluded from the sort of baseline look-see. What is the strategy in maternity at the moment?
So they are still using anti-embolic stockings because that's within their guidelines and protocols. However, once we pitched this, and funny enough, it was the lead obstetrician who chairs Grand Round was giving party emojis because she was quite happy to think we're getting rid of stockings. We will only be using IPC in our highest risk patients. So the plan will be for them. They will come on board as soon as the trust strategy launches. They're very happy about that.
Okay.
The reason why we didn't include them was because they use a very separate IT system. Because of time constraints, the students collecting the data didn't have access to it.
Great that you've got buy-in from the obstetricians as well, and presumably the midwives. If there are any midwives on the session, I'd love to know. I'd love to hear from you guys, actually, especially because I think there's a little bit of a comfort from many health professionals, but maybe from midwives, about a patient being in stockings. Actually, lots of women are pretty mobile. I don't want to generalize. Everybody's birthing experience is different, but you know, this is a fundamentally largely fit and well population, mobile, especially if you've got other kiddies to look after. You're not a necessarily immobile, only relatively. So yes, but I don't know how well that will be received when we suggest it, as our plan is in the next few months to do that.
Yeah, I think with that, it's getting out to the wards and, you know, reassuring those people with those concerns that, you know, where the evidence lies, and if it's placebo in a sense, we have to, although it's visible that we're doing something, if it's not working, we have to address that.
Yeah, because they're not harm-free either, and I think it's easy to think that stockings, like, what harm can they do? They're not harm-free. There's low risk, but they're not without consequence. Right. We've had a question from Claire in the chat, and there's some questions in the Q&A which I'll come to. So she says, hi, a patient being able to walk 10 meters or more doesn't mean that they will. How much intervention with patients will you be doing to keep them moving?
Are you able to?
I think that if the patient is choosing not to mobilize rather than being unable to mobilize, the risk would still be the same, right? So if they're choosing not to mobilize, then obviously attaching them to a device wouldn't be the first port of call, and sort of interventions with encouragement and physios and that kind of thing, and confidence and understanding what the barrier is would be preferable. But then ultimately their risk, if they're choosing not to mobilise, would be the same as if they can't mobilise. And so it might be that if they can't have pharmacological prophylaxis, that they might be indicated for IPC.
Yeah, thank you. Thanks. And another question from Anonymous. Do you offer IPC for bariatric patients? Do you struggle with sleeve size availability? And do all patients receive IPC in addition to pharmacological prophylaxis? I think that is specifically in the bariatric patient group.
So Guy's and St Thomas's are for bariatric population. When patients like that, there are procedures, they'll go to King's. However, if there's a bariatric patient who's currently an inpatient here, they won't have both. If the rule will be, if you can have pharmacological, you won't need the mechanical on top of. We have not yet came across the issue with regards to sleeve size, but you said there's availables on the market.
Yeah, the company provide the various, I forget the exact sort of, it's done in measurements and circumferences rather than weights, obviously, and I can't tell you the exact measurements off the top of my head, but I'm sure they would be able to procure bariatric sleeves.
Yeah, and presumably these bigger patients are on bigger doses. The ones for whom pharmacological prophylaxis is suitable are on bigger doses. So if they're on low molecular weight heparin already, they're on a bigger dose because of their size. Yeah. So that sort of negates the need for additional, because they're getting additional via the pharmacological means. Yeah. Great, thank you. That appears to be it on the chat. If anybody's got any last minute questions for any of our guests or comments about your practice, then now is the time to make them, either in the question and answer or on the chat. In the meantime, I will say thank you to Joe, thank you to Thrombosis UK, and thanks to our presenters, Ellen, Sarah, Anthony, and Tina in her absence. I will encourage you to check out some of the talks from different elements of the Thrombosis UK